Welcome to Lehman College. This event is being recorded and live streamed across the CUNY system as well as abroad. My name is Maria Isabel Roldos, and I currently serve as the director of the CUNY Institute for Health Equity, as well as an associate professor from the Department of Health Equity, Administration, and Technology. This is an institute that coordinates research, teaching, service, and community engagement with the goal to eliminate health inequalities, reduce health disparities, and promote health. It is, in our most recent strategic plan, CIHE was tasked with 4 goals. 1, promote workforce skills development related to health disparities research and health equity. 2, foster CUNY institutes to develop analytical skills to address health disparities and inequalities, promote diversity and health equity knowledge and skills among CUNY students and alumni in an environment that fosters wellness, inclusion, and belonging. 3, develop successful outreach and engagement strategies with internal CUNY partners and with external community stakeholders, academic and political partners to improve population health and community accountability. And 4, advance the science of health disparities research and health equity and promote health disparities research to achieve health equity. As a research institute that seek to advance the science and health disparities, we investigate and explore the causes as to why disparities exist in health outcomes. We want to know if there are differences in health outcomes between population groups. We want to dissect and look at a health outcome to understand if the difference in the onset of a disease if the difference in the onset of a disease, if there's differences in the progression of the illness of the disease, if some populations have more aggressive progression than others, and ultimately, we want to understand differences in why people die more rapidly or more often than others. Fundamentally, we want to investigate the causes of these differences and the characteristics of those that experience the health disparities in that health outcome. Immigrants and migration populations are rapidly becoming a population that is experiencing or will experience a health disparity. Before studying it, we need to understand that immigration and migration are used interchangeably. By definition, migration is the movement of people from one place to another, within or between countries. The reason why people migrate to a place other than a place of birth is often the cause of accrued disparities in that person's life course. Some of these causes include seeking better jobs, access to health care, running from famine, war, national disasters, fleeing persecution, looking for political or religious freedom, among others. As a researcher, we are faced with asking a study participant, where are you from? The answers we get back are as complicated as the question. Are you asking me my race? Are you asking me my culture? Are you asking me where I live? Are you asking me where I was born? Do you want to know where my parents are from? That's what immigration does to us. As a health disparities researcher myself, we review current paradigms to challenge them through rigorous study design, to collect and process data with the hope to develop interventions, inform programs, and policies. According to the U.S. Census Bureau, the immigrant population in the U.S. is growing. The number of people foreign-born is reaching a record high to close to 46 million people. These estimates indicate that the total immigrant population grew by almost 30% between 2005 to 2022. Foreign-born Americans made up 13.9% of the U.S. population in 2022. The same data indicates big gains in the number of immigrants from Latin America and Asia, as well as refugees from Afghanistan and Ukraine. Migration is movement. The type of migrant differs largely in the mode of migration. If you or your family member migrated by plane, by boat, or by foot, that variable alone can determine great differences in your path to opportunity and in health. Your port of entry in the U.S. is not necessarily your permanent place of living. Migrants move to where there is history of their communities or where there's a support system that will allow them to integrate and to find jobs and settle into those communities. Furthermore, migration among the U.S. nationals, foreign or non-foreign born, is also changing our communities. Dense core counties of major U.S. metro areas are experiencing net decreases in flow into the city, while other suburbs and similar smaller cities saw a net gain. In other words, people are moving outward to the suburbs with their own core metro area, but also far out to satellite cities or even major urban centers that might still give people proximity to the region. In sum, who migrates? Where do they come from? Where do they settle? What are the causes of migration affect health, as well as related to other causes such as national security, economics, climate change, and more. With this brief introduction, I would like to extend the warmest welcome to New York State Assemblywoman, Mrs. Yudelka Tapia. Yudelka Tapia is serving first term in New York State Assembly, representing 86th Assembly District, which includes the neighborhoods of University Heights, Moreland Heights, Mount Eden, Kingsbridge, Tremont, Fordham, and the Bronx. Yudelka was born in the Dominican Republic, attended OMM University in Santo Domingo, where she organized her fellow students against domestic violence, political corruption, and served as the president of the Unión Democrática de Mujeres, a national organization that organized and educated women. She later obtained a Master in Science and Urban Policy and Leadership from Hunter College. Since immigrating to the West Bronx over 30 years, Yudelka has made the community her home, raising 4 sons here and sending them to New York City public schools. For 23 years, she was worked as the senior auditor for the New York City Comptroller's Office. Welcome. A reminder, keynote panel is being recorded and live streamed across CUNY and the campus. Once again, welcome.
Thank you for that introduction. Yes, I am Yudelka Tapia, and I'm happy to be here, but I wasn't born here. I'm an immigrant too. We're talking about the immigrants here. I'm an immigrant too. And I got to this country when I was very, like you heard, I was already 20 years old. Yes, my children were born here, but they still believe that they are from the Dominican Republic. Because, I mean, we haven't lost our culture, we haven't lost our language, which is part of who we are and what we bring to this country when we come. And it is just so important that we talk about these issues, especially because, I mean, as you know, we are in a humanitarian crisis right now in the state of New York and in the whole country. If you see, because, I mean, during Biden administration is when more migrants have come inside to the United States. So, and that is a good thing for us, because, I mean, we know that if our population doesn't grow, we go down, and then we're going to be a population of elder people that are not future for our future generations. So immigration is good, and that's the way we should see it. And as of November, here in the city, we have received like 150,000 migrants, mostly from Venezuelans and other countries, from whatever country, but the majority are coming from the Venezuelan descent. And half of it, like 70,000 of them, are under our care. The city of New York have to care for them because, as you know, the Constitution of the state of New York says that we are, as a state, we have to provide shelter, food, education to anyone that need it in the city of New York. So for us in here, it's a mandate, and we had to do it. But I mean, at the same time, we're struggling, and the mayor is struggling, and all of us are struggling because, I mean, we'll have to look for the resources for make sure that not only we take care of our immigrants, but also that we can offer them the opportunities that they need. Because, I mean, immigration, and the way they're immigrating here, it's a human rights issue. I mean, education, shelter, and food is a human rights issue, and we have to take care of that. And community organizations have been called to join public officials, faith-based organizations, funders, people that have the money to give us money, healthcare services, and other agencies to work collaboratively to face challenges related to housing, food insecurity, mental health issues, lack of social services, homelessness, violence, and many other issues that we have in our community that are being exacerbated now with the migrant issues that we have and the humanitarian crisis that we are facing today. Important to this issue is the community organizations' preparedness to face these challenges, and that is exactly what you, Dr. Delgado, are doing here, with these trainings and this summit, just talking about how actually we're gonna face these challenges. This summit was planned and developed to provide organizations with skills development workshops, as well as opportunities to connect with researchers and experts to engage in meaningful work. That's exactly what is needed in this type of crisis that we have, humanitarian crisis that we have. Events such as this summit seek to facilitate collaborations between community organizations, faculty, and researchers, and planned and hope to receive support from local, state, and federal agencies, which is exactly why we at the state level put $1.5 billion to make sure that many of the funding that is needed to deal with this humanitarian crisis we could take care of it. Still much to do. You know that it's going to cost us like $12 billion for the like three years to actually deal and to actually make sure that our migrants actually have been taken care of. And we're fighting for it. We know that the money is there. And as elected officials and as an immigrant and as a Latina, we are not going to stop fighting to make sure that they get what they deserve. The keynote panel is bringing experts. Yes, we have all these experts here, guys. In demographic and sociology scholarly work on the socioeconomic conditions of people of Dominican ancestry, like Dr. Hernandez, in the US, federal authorities promoting inclusive, equitable, accessible language access tools that comply with civil rights laws for limited English proficiency persons and their families. Yes, that's a barrier that we have to make sure that we can cross. And I know, because when I got here, I didn't speak English. I still don't speak English. But I didn't speak English. And of course, that's a barrier that we have. And I just try to learn every single day. But I don't want to leave my accent. I want everybody to know that I'm an immigrant, that I wasn't born in this country, and that it's possible for us to actually make changes and to change people. So, and an international experience to examine the status of gender-based violence and sexual and reproductive health services in Ecuador to identify sociocultural and institutional factors impacting migrants' access to these services. What I try to say is that this summit is so important that we not only do it now, but that the information that is coming out from here, we can share with many people. And I assure you that there's gonna be so many town hall meetings that are gonna be done because of that. And I'm gonna do a town hall meeting in my district, blocks from here, just to discuss that, especially because I have a lot of those migrants in my district. I have 642 students, migrant students, that got here that are in my schools in my district. And I know how we're fighting to make sure that those students have everything that they know, that the parents are not changed from shelter to shelter, so they don't miss or they lose the school and the friends that they have made in the school that they've been going. So that's something that we are fixing, that we fixed. In my district, none of the migrants can be moved from the schools that they're already going to another school and just to change and to make because what they need is stability. So that's something that I'm taking seriously, especially because, we know that education is the great and the only equalizer that we have. Thank you. Thank you. Thank you for being here and for inviting me to this.
Thank you, Assembly Tapia. And now we have the keynote address from President Fernando Delgado, President of Lehman College.
Thank you, Professor. Before I begin my formal remarks written out, I want to say this is the end of the academic semester, the fall semester. And as you get to the academic semester, students get tired, faculty get tired, presidents, we get tired. And some of us start to feel bad for ourselves. But today, in the last hour, I feel better because I complete my 30th month as the president of Lehman College. I've now had, no. Clap comes in a minute here. I get to sit down here next to President Emeritus Fernandez, who did 312 months or so as president. And I'm inspired by two things. One, he smiles regularly, still. And two, he comes back. And so I'm not going to feel so bad for myself today or tomorrow as we finish this week. And I'm a little bit more energized. And Ricardo, as always, thank you for coming back home. To the rest of you, good afternoon, esteemed guests, faculty, students, community members. Yes, I get the honor of having the best presidency in the City University of New York system. I get to be president of Lehman College. And it's my great honor to welcome you all to the CIHE Migration and Health Summit. Just over a decade ago, in 2009, the CUNY Board of Trustees established the CUNY Institute for Health Equity, or CIHE, right here at Lehman College. Since its inception, the center has been steadfastly committed to focusing on the social determinants that influence the physical and mental health of New York City's most vulnerable and underserved racial and ethnic populations. Over the years, we have endeavored to make CIHE a hub for research collaborations, not just locally, but also nationally and internationally, nurturing health disparities and health equity research that has real, tangible implications for urban cities in the US and abroad. In 2020, we embarked on a collaborative strategic planning process involving distinguished faculty across CUNY to determine the future direction and focus of the Institute for the next 5 to 10 years. And it'll be a vibrant 5 to 10 years. The unique collaborative nature of CIHE has made the Institute an exceptional platform to develop science and enrich educational programs. Positioned within the School of Health Sciences, Human Services, and Nursing at Lehman College, CIHE is ideally placed to promote faculty and student scholarship, enhance experiential learning, and cultivate student researchers that will progress to graduate education and contribute significantly to this field. Today, we gather for day 2 of the Academic Summit, centered on the theme of migration and health, viewed through the lens of human rights. Organized by CIHE, this summit aims to coordinate research, teaching, service, and community collaboration, utilizing data analytics to eradicate health inequities and advance the science of health disparities research. Over the past 2 days, CIHE has provided free skill-building workshops to community-based organizations, hosted discussion sessions on the role of anti-racism frameworks to addressing health, and organized a CBO fair to facilitate collaborations between CBOs, faculty, and researchers. In closing, I want to express my deepest gratitude to Professor Maria Isabel Roldos for her tireless efforts in organizing this event. And I know they're tireless because we first met about this 1 year ago. She doesn't give up. I would also like to acknowledge the participation of our esteemed moderators and panelists, as well as Assemblymember Tapia, always a great supporter of us at Lehman. Thank you. And Councilwoman Purina Sanchez. Your contributions over these 2 days have been invaluable. Personally, as somebody who worked in a hospital for 3 years when I was in college and got paid $1 an hour extra every time I was at work because I was certified bilingual, I can tell you from working in outpatient and emergency services that when you're there as a migrant or a non-native speaker and you do not have the capacity to advocate for yourself, to fully explain your pain, your injury, your illness, or understand the courses of treatment being offered, you are a profound disadvantage. And while we always like to say we welcome migrants into the US, we are flawed in how effective as hosts we actually are. And you never see this more clearly than in our health system. So, an important topic, the best place to have the topic, wonderful scholars and community activists. And again, welcome to the CIHE Migration and Health Summit. Thank you all for being here. And here's to 2 days of productive discussions, collaborations, and learning. Thank you all.
Thank you, President Delgado, for your warm remarks. And now we invite our speakers and our moderators to the table. To join us here at the front of the stage, Dr. Ramon Hernandez, Dr. Lauren G., and Dr. Cheryl Martins, as well as our two moderators, Dr. Noemi Rodriguez from City Tech, the Department of Human Health Services School of Professional Studies, and Dr. Mira Gural from Lehman College, Department of Speech, Language, Hearing, and Science from the School of Health Sciences, Services, and Nursing. Please, welcome.
Good afternoon. I'm Dr. Rodriguez in the New York City College of Technology in the Health Sciences Department, currently Director of the Healthcare Policy and Management degree, which just came about in spring 2022. So really excited about it, and it's great to see this work that's being done at Lehman and continue collaborations to move forward. I'd like to welcome everyone. Thank you so much. And to our panelists who are here to accepting our invitation. We look forward to a wonderful set of presentations and discussion. We will commence presenting the presenters. They will present their slides, and then we will sit down for a Q&A between the panelists, and then we will open it up to the public, time allowing. Thank you. So the first panelist will be Dr. Ramona Hernandez, and to share a little bit about her. She is the director of the CUNY Dominican Studies Institute and professor of sociology at the City College of New York. She is also a member of the doctoral faculty of the Department of Sociology and the MA program in International Migration Studies, both at the CUNY Graduate Center. Dr. Hernandez's research interests include the mobility of workers from Latin America and the Caribbean, the socioeconomic conditions of Dominicans in the United States, and the restructuring of the world economy and its effects on the working class. A renowned public speaker, Dr. Hernandez has lectured at numerous universities and community venues in the US, Europe, and the Caribbean. She is the author, co-author, and co-editor of numerous books, book chapters, and academic journal articles. One of her groundbreaking books, it's on the socioeconomic conditions of Dominicans in the US, the mobility of workers under advanced capitalism, Dominican migration to the United States, Columbia University Press, which was winner of the outstanding academic title in the prestigious academic journal, The Choice. Dr. Hernandez is also an editor. She sits on the editorial board of the Latinos Exploring Diversity and Change, the academic journals Latino Studies and Camino Real, Estudios de las Hispanidades Norteamericanas, the Sociological Initiative Foundation, and the Instituto Global de Altos Estudios en Ciencias Sociales in the Dominican Republic. I would like to welcome Dr. Hernandez.
Gracias, muy amable. Bueno, I had to take 1 minute to express my gratitude for this invitation to Professor Roldo. The reason for this is because I have the the honor and the pleasure to speak before a person who has been instrumental for the birth and the maturity of the CUNY Dominican Studies Institute. When it was in the imagination of, when this institution was in the imagination of the Dominican people, El Presidente Fernandez, he was the president of Lehman College. He had a lot of clout, and I remember this vividly, and I know that there are some students here. I was a rebel, very rebel person, young person, and remembering this thing brings tears to my eyes. But President Fernandez, along Presidente Isaura Santiago, who was a Hostos Community College, supported the enterprise. And the support meant speaking to the chancellor on behalf of us, of a people that had, at that time, no legislators sitting there at City Council, Assembly. We had nothing, nobody. So it was because of them we are here. So it is it's an emotional time for me, because this is the first time he's seen me speaking, and so he can see what he has done part of the legacy. And of course, having two presidents, looking at you. I graduated from CUNY, not like my sisters here, so it's also a challenge. I'm gonna try to do this thing as fast as possible. The Honorable Tapia said she doesn't speak English. I don't speak English either. So así que vamos a ver aquí, I will probably move from language to language, and que Dios nos ayude, ¿verdad? Entonces, a ver, and also I had slept very little. I came from the Dominican Republic working. Let me see if I can move this thing. Okay, con la grande. How do I move this? With the big one first? Wait a minute. Okay. I have to point that way? ¿Tú quieres tratar de moverla? Que si yo no la muevo. I know I move nothing, but vamos a ver. I am so sorry about this. Again? Oh, okay. Really, really fast. This is just to show you the evolution of the migration process of the Dominican people. It is, with the first Juan Rodriguez in 1613, and then the people don't know, this is one of the latest research in the Dominican Studies Institute. Dominicans who came through Ellis Island, about 5,000 of them came, and I'm not gonna tell you some of the secrets, but stay tuned. Please do, is that me doing that? And this is, I want you to see the trajectory of the migration process. It is very healthy, as you can see. And the things that you saw, let me see if I can do this. Nope, this is the one. Pero bueno, ¿qué es lo que pasa? Okay, see, that's the birth of the Dominican Studies Institute. We have it here. What I'm going to do is to show you the importance, and I'm glad that President Delgado is here, the importance of doing, focusing on particular group of people rather than the whole Latino as a whole, because you will see differences among us that are important for each group. So I will do that. Because I was told that there were going to be students in here, and I wanted to emphasize that. This is what you're going to see in this presentation. And also focusing on the Dominican people as well. And this is a portrait of them from a social economic point of view. And so here you have the largest group, Hispanic population in the US. This is kind of self-explanatory. You have the Dominican people in the 5th place. And I don't know why my thing is not working. Okay, the interesting thing is that at some point in the year 2000, I don't see this well from here, Dominicans were kind of the 4th largest group, and then they no longer that, is now the Salvadorian, and that have to do with that legislation that passed. And so it's moving by itself, by the way. Yeah. What is interesting is that this is now, you see the migration of the Dominican people obtaining the legal form, the legal resident here, and it's all over. But the important thing here is that, cógelo, pero bueno, señor. Okay. Is that the growth of the Dominican people that you saw before does not necessarily have to do with migration, with them coming here. Because as you can see at the end, which I think is, nope, it doesn't work. Well, you see the red thing? Nope. Wait. When you saw the red thing, it's declining. So there are not many Dominican people getting their papers to come in here. It is healthy, but not as many as before. So what explained the growth of the Dominican people? And now we're gonna go to the next slide, hopefully. Nope. Yeah, here it is. Now I know. Here what you have is the birth of children in New York City, and you have the 5 largest immigrant groups. And I know here the question mark in 2020 is because the Ecuadorian people, my sister Roldo's home in 2010 was among the 5 groups having more children. That's no longer the case. Now we have the Bangladesh, and I have a question mark porque no sé de dónde vinieron. They came out like that. But what is interesting here is that the Dominican people have remained systematically on top of all of the other immigrants having children. I had just one, so don't put this on me. Don't do that, okay? So the growth of the Dominican people, then it's not necessarily because you have more people coming from home, but because of children that are being born here. That's the thing in here, right? So, here you guys, yeah. Okay, so here we go. Now that you know that there are so many Dominican being born here, the second question is, so how does that reflect in terms of the whole, right? And here you have it, a comparison over this is a historical comparison, right? Of how the immigrant population has been kind of getting smaller as compared to those US-born Dominicans. And this, for you who need to do papers, what are the implications of this for the Dominican people as a whole, right? So here we go. This is the Dominican people who came before the year 2000. As you can see, 47% of the immigrant population has been here for a long, long, long time. And when you put that together, vamos, muévete. Oh, okay. When you put that together with a US-born Dominican, that creates 93% of the Dominican people had been here for a long, long time. And then the question is, what kind of mentality do they have? How do they see themselves, right? Because it's, when we speak of immigrants, what is the meaning of that? You need to always ask, how long had that immigrant been here? Okay. And here's the question. This is also to dissipate some things that you had heard, that Dominicans don't want to become citizens because they want to go home. Well, the numbers show something different. The longer they are here, the higher the rate of naturalization. And this is kind of typical for every immigrant group that we have analyzed. But here you have it, so no more. We wanted to stay, at least those who become citizens. Se movió rápido. Okay, está bien, vamos. That's the, and this is going to show you the geographic distribution of the Dominican people in the US. And we're going to, come on. Well, here you have the places with the majority of the Dominican people in the US. And as you can see, New York still remain the hub for Dominicans, as 40%, almost 1 and 2 Dominicans reside here. So now what we're gonna do is, because now you know we're gonna concentrate in New York City because of that weight of the Dominican with some social economic indicators. And what do I have here? You got it, bear with me. I don't see this thing too. No, espérate. See, no, I had to hold this thing here. So what you have here is the largest groups, Hispanic group, as compared also with the other racial groups, and you can see it is kind of self-explanatory. The reason why I have no Hispanic, Asian, and Dominicans highlighted is because you see that they are the people that are growing in the city as compared to the others. And I want you to see that. Okay, and then here, this is the population of Dominicans distributed in the city of New York, and as you can see, the Bronx was nowhere to be found in 2000, but this is not the case anymore. The Bronx has taken over the Dominican people in New York City. And don't go out and say this, because I have other elected officials. I didn't say this, So, okay, and then, now some things that are not that nice. Here you have changes in poverty rate for New York City, and these are the populations in there, and what you can, hopefully, nope, well, it's not it's highlighted in this PowerPoint, but if you look at the dates, the Dominican people had been in trouble with this category historically. There you go, wow. So as compared to the rest of the group, okay? That's what we see there. And then, you know, we look at this thing from several angles. It's not just one question. Then you add the question, why they're so poor? And so, ¿pero qué pasa? ¿Se volvió? No, it has to do with the money that they bring home. And here you have the per capita, which is, you know, you take all the people who live in a family, and then you divide all the money that goes in there into that family, and you see how much is allocated to each person. That's per capita. And they have the lowest as compared to the other. And then we continue to kind of dig the numbers and see. And this is an interesting one, because the homes headed by single women went down in 2020, ¿verdad? But yet, Dominican people, as compared to the groups that you have here, continue to have a kind of monopoly on that. There are more families headed by single women than any other group, and that's kind of historical. And that also is going to have an impact on your social economic standard. In here, the poverty rate for homes that are headed by women, and here you have it. It's just not nice, but we have it and we can talk about it. Why are Dominicans so poor? Is it because they don't work? You know, those are the questions and things that people tell you sometimes, and that's not true. Labor force participation rate, what does that measure? It measures people that are working, actually working, and then people that are looking for a job. This is what this measures. And what you can see, it's almost pretty similar. In the majority of the cases, los Hispanos, los Latinos, and Dominicans, right, they're pretty high. And the, you know, the 70.2, it means 7 people in 10 at that time of Dominican ancestry were working, right? In this case, it's the male, and 60% arriba of the female. As compared to the other, you see that it's very stable. Yeah, they do work. So what is it that is keeping them in trouble? And the same thing happened with the Latino. I have it there, right? Everybody lost, went down, but some people were affected more than others, as you can see. And then, so it's not because they don't work, right? Their poverty. That have to do with the kinds of jobs they do, and that have to do with the kinds of salaries they earned, right? And here you have this comparison of English language. And one interesting thing is that the Dominican people are the lowest group that speak only English at home as compared to the others. And of course, they have the highest percentage of people who don't speak English. That is going to affect su bolsillo, ¿no? Ahí está. Entonces aquí, where do they work? Here you have it. The service workers, these are, Dominican have a monopoly on the aid, people who work, attend, other people, and they don't pay. That's the answer. It's not service worker, white-collar jobs in una oficina. No. It's the very low end of the service. Come on, no te vaya. And of course, operators and fabricators. At a moment when this society, this city, is not doing that anymore. They still have a very large proportion of them in there. So that explains then their low income and their poverty and so on. Unemployment is very high, as you can see, compared to the other, because those sectors are affected with all cuts and things like that, and we are going to continue really fast. And then you have more unemployment data in here to show that, they don't look good. And then, the annual income of a home, the first one that I showed you was per capita. Now this is the whole thing. When you look at this thing, they're still in trouble, even when you compare them with Latino, más bajito, no? So it's, to scratch your head. Maybe it had to do with the education or something, you ask, right? And here we are. College education attainment of the U.S. population, and then it's historical from 1990 to 2019. And what is interesting is Hispanic and Latinos, they are doing very well in 2019. I couldn't do the, I had the 20 numbers, pero no pude hacerlo anoche. So even though the Hispanics are doing very well as compared, right, to the past, from 10% in 2000, for instance, male and female. Now in 2019, Hispanics is 16 and 19 for female. Still, Dominicans are ahead when it comes to that category. So it is not education really that affect these people. And here you have it even more. I highlighted the green thing because if you compare the United States youth, Dominican youth, Hispanic youth, the Dominican people have more youth enrolled in school or college than any other group. So the future should be better is what we have in mind, right? It's okay. And school, college enrollment rates in the U.S., people from 18 to 21 years of age. We look at the data from many different angles. That's the trick. Not just 2 or 3 like people do. You gotta ask questions to the data and to corroborate whether what you're seeing is true, right? And here you have it once again. Only the Cubans are ahead the Dominican people when it comes to college. So, and now, the thing that brought us here, this is very new. This is a study that we are doing right now. It's going to be released soon, and this was inspired because of this conference. We never thought about doing insurance and that kind of thing, but we sat down and here it is. So how are Dominicans doing in terms of insurance? Here we are, the United States, Latinos overall, and the Dominican people. Uninsured people, these are people who don't have insurance, health insurance. And when you look at 2010, Dominicans, 21% of the Dominican people, I think I'm reading this thing, were uninsured. Now it's only 10% of them as compared to the Latinos overall in the United States. So we are doing well. We have, health insurance as compared to the other. I'm almost home, I'm almost there. And let's see, muévete. Okay, so here we have it with the Latino subgroup compared once again. No, is that the one that I had before? Okay, and again, if you look at Dominicans, Cubans, Salvadorian, Puerto Rican, and Mexicans, the Dominicans look very good when it comes to health care. So they had insurance as compared to the other groups. So this is a good thing, right? And here you have it, Dominican immigrants with US born. We wanted to continue to ask the data, so who are the people, right? And the US born Dominican have a higher rate of people with insurance as compared to immigrants. Dominicans immigrants are the one with the low, right, with the lowest rate of people with insurance. So, and okay, I think this is the one. Latino groups with no health insurance in New York City. Now, this is the city, right? 16% in 2010 for the Dominican people, 6%. Legislators, Dominicans are insured, quote unquote, as compared to the other Latino subgroup, right? And then, so the question is, because you know, I'm gonna keep asking questions. What kind of insurance do my people have? Stay tuned, because that's the kind of research that is coming out now. I need to disentangle this. They cannot be that poor and have health insurance. There's something going on in there. So that's the question. And I'm gonna finish with the following. Let me show you this, and then I'm gonna go with the second question. These are Dominican male and female. And as you can see, there are more Dominican boys than Dominican girls. And so the question is, if you want one of those, this is a Dominican boy running away from all of those young women who wanted to catch him. So going back to the question I have, okay, vamos, aquí está. Since there are more Dominican women than men, who are Dominican women doing the rumba with? Let me put it to you this way. That's another research that is coming, and I finished. I think I did it on time, right? I'm sorry that I spoke too fast, but I wanted to give time to the other panelists. Thank you.
Thank you very much, Dr. Hernandez. It is my pleasure to now introduce Dr. Lauren G. Lauren G. is a Principal Deputy Director at the Office for Civil Rights, OCR, United States Department of Health and Human Services, where she leads OCR's budget, operations, strategic planning, and works directly with OCR's 11 national offices and supports the Health, Information Privacy, Data and Cybersecurity Division, among other things. Previously, Lauren served as the Chief of Staff at OCR, where she led day-to-day operations and worked to lead a national reorganization to help drive vigorous enforcement of the law and more efficient use of resources. Lauren also served as Deputy Assistant Secretary for Mandatory Health Programs at the Office of Assistant Secretary for Legislation, where she managed congressional affairs and for the Secretary on mandatory health programs, focusing on the Centers for Medicare and Medicaid services. It is our pleasure to hear Lauren's talk now.
Hello, everybody. Just a few things. So I'm Lauren G. I'm the Principal Deputy Director for the Office for Civil Rights at the Department of Health and Human Services. My pronouns are she, her, and then for those who may not be able to see me, I'm about 5'5", brown eyes, brown hair. I put on red lipstick today, so just especially for y'all. If you hear an accent, I'm actually originally from Mississippi, so I do have a Southern accent. So traveled far to see y'all, just kidding, I'm actually located in DC. So I work for the Department of Health and Human Services at the Office for Civil Rights. We enforce laws to protect medical privacy and ensure that you get health care free from discrimination. Here at the Department of Health and Human Services, we work to improve health care and human services to meet the diverse needs of patients across the country. Through our civil rights authorities, my team at OCR is constantly thinking about what kind of barriers patients may face when they go to the doctor or trying to get to the doctor, and how those could lead to adverse outcomes. One of the priorities of the Biden-Harris administration is making sure that federally funded programs are accessible to all. So making sure that includes those with limited English proficiency. Language access is also a priority for Secretary Javier Becerra. He grew up actually being the main translator for his parents when they would go to medical appointments, so this is really close to his heart. And he really understands what it means for patients to be able to properly communicate with providers. I also have a similar experience. My grandfather and grandmother immigrated from China in the 1950s. They settled in Mississippi. I know that's weird. But after my grandfather passed, my grandmother was wholly reliant on her children. And so growing up, I watched as my father translated many complex terms and ideas for her. Luckily, he got his medical degree, and so when it came to healthcare issues, he was able to help her and communicate in a supportive fashion. I think we can do next slide. Oh, am I doing it? Thank you. Oh, thank you so much. I'm not coordinated with technology. So here I just have a map of our regional offices so you can see our presence of the Office of Civil Rights. So HHS, we have an Office for Civil Rights, but Department of Education has one, Department of Justice, Department of Homeland Security, so there's a lot of us out there. We have 8 regions with 11 regional offices, and we actually have one here in New York City that represents our Eastern and Caribbean region. Later in the presentation, I'll go through how you can file a complaint with us and how you can reach out to us if you feel like you or someone else you know is being discriminated against. Next slide. So this is a lot of text on a slide, and it's kind of like jibber-jabber if you're not like a legal person. But these are the authorities that we work under at the Office for Civil Rights. So these are the authorities we work under to make sure that there's non-discrimination on the basis of age, disability, sex, race, national origin, and ethnicity. So we have Title VI of the Civil Rights Act of 1964. We have Section 5057 of the Patient Protection and Affordable Care Act. That's the newest one. We have Section 504 of the Rehabilitation Act of 1973. And we have Title II of the Americans with Disabilities Act. So when it comes to discrimination in healthcare, we want to make sure that we're not doing that. And so we're thinking about what jurisdiction, who can we reach under these authorities. And so the people that we can reach under these authorities are what we say federally funded. So anybody that gets any sort of federally financial assistance, that could be, in the healthcare case, that can be health providers, hospitals, that could be folks who have grants from different divisions within HHS. And so we can reach in and make sure folks aren't discriminating. This also includes state and local governments as well. So I'll stick just to this slide for a minute, and I want to point to Section 1557. This is really our kitchen sink of non-discrimination law. We actually just put out a proposed rule. For those who don't know what a proposed rule is, it's basically we're updating what was in the ACA and trying to make it stronger. And so what we did in our update that was released in August is that we have a few provisions that strengthen language access services. So one, we will make sure that we require language access services to be provided free of charge. They need to be accurate and timely. They need to protect the patient privacy and the independent decision-making of the limited English proficient person. We also have specific requirements for translation interpretation services. This includes those that are via machine translation and those that are video remote interpreting. And then I think one of the biggest ones for Section 57 that we really strengthen is that we require hospitals, providers, et cetera, to provide a notice of availability of language assistance services. What we find a lot of times is health providers, hospitals, et cetera, don't always know that they're responsible for complying with civil rights law, especially the language assistance part. And so this really strengthens that and puts folks on notice and also allows patients to know their rights. Next slide. So when we think about those who have limited English proficiency and what population we're really looking at, we know that 21.5% of the population in the US speak a language other than English at home. We also know that 1 in 4 adults have some type of disability. And so when we're looking together, we know that there's higher rates of disability and higher rates of limited English proficiency in certain communities of color and also in lower income communities. So we're looking at a population that already faces a lot of barriers, right? It's getting to the actual physician's office, being able to be treated in the physician's office, and even communicating with the physician. So we know that there's a higher rate of disparities among communities with limited English proficiency. What we know before the ACA is that we found that almost half of those with limited English proficiency were uninsured. So that has gone down with the implementation of the ACA, but there's still a lot of barriers that folks are facing that we are trying to overcome. All right, next slide. So when we're thinking about communication barriers, I'm sure that y'all have faced this in your own homes, right? You're thinking about the challenge it is to make appointments. How can you even get in touch with a doctor or a nurse if you're not able to communicate and they don't offer a service and you don't know that they offer translation services? I also think about, when I think about my grandmother, it's like the lack of ability to understand the diagnosis, understand what's actually happening, understand a treatment plan. And as a result of lack of understanding a treatment plan, it's really you also face a barrier in actually adhering to the treatment plan. So that can be really difficult. These things, obviously, these communication barriers will, lead to an increase in readmissions, will lead to adverse health outcomes, and finally could lead to life-threatening conditions. Next slide. So how do we enforce this law? Well, we do a lot of investigations, but when we're talking about language access in particular, we're talking about an entity. So when I say entity, a health provider, hospital, et cetera, making sure they're taking reasonable steps to provide meaningful access. This is kind of this is legal jargon. What does that actually mean? It is legal jargon. So we'll go to the next slide. So what that means, right? Reasonable steps. So here I've listed out some reasonable steps. It's making sure that the provider is training staff effectively to work with interpreters. It's ensuring that the interpreters are actually qualified, right? You can't just pull someone off the street. They need to have a certification. They need to have a few years of experience. You also need to make sure that documents are written in plain language, that they're easily accessible, and also that we also recommend that you translate in the top 15 languages of that geographic area. Understanding that can be hard. And also one thing that we have also faced in our translated materials is making sure they're proofread. So you can hire sophisticated translators, but then luckily we have some proofreaders at our office, and they'll catch things that actually make no sense to that community or in that dialect. So that's also very important. The one thing I did want to share with you that's not on here is just kind of knowing your rights. So if you have someone who is limited English proficient or you're helping them, you as a family member or friend, you're definitely welcome to do that, but the provider should not require you to be that interpreter, right? You can actually refuse that, and they should be able to provide a translator or someone free of charge. If that's not happening, you should file a complaint with us. Next slide. So prioritizing language access. So we're doing this and making sure other people are following the law, they're being compliant with federal civil rights guidance, et cetera. But what are we actually doing at HHS, right? So we have grants that go out to folks, we have actual service providers that are helping people, and we have communications, right, on the COVID-19 pandemic, et cetera. We have to make sure that we are also being held accountable. Next slide. So one of the things that we did, this actually was dormant under the previous administration, so we were super excited to relaunch it under our administration, was at HHS, the Office for Civil Rights relaunched what is the Language Access Steering Committee. It's a bunch of big brains that get together and make sure that we're making progress in the goals that we want to, and also that we're holding ourselves accountable. Let's see, and so I just wanted to highlight a few divisions that are doing some really great work. So, and you could be like, yeah, they're not doing that great work, but you can also talk to me about that later, because we can always improve. So first we have the Centers for Disease Control and Prevention. They actually established a rapid response team to produce COVID-19 related materials in additional languages and multi-languages, so those were actually accessing communities. We also have the Centers for Medicare and Medicaid Services. They actually launched a helpline, 1-800-MEDICARE, and have prompts where you can access other interpreters in other languages like Spanish, et cetera. Health Resources and Services Administration, those are the ones who are really our community health workers. So folks who go to like a federally qualified health center or a community clinic that's generally funded by HRSA. They actually awarded more than $8 million to 18 institutions to make sure those institutions were training primary care providers, such as physicians, assistants, medical students, et cetera, and a way to provide culturally and linguistically appropriate care. Because that's always what you need to do to accompany your language assistance services. And then we have the Office of Minority Health. This is probably my favorite office. I don't know if I'm supposed to say that. But they actually awarded $4 million to 11 organizations to develop methods of informing individuals with LEP, so limited English proficiency, about the availability of language access, right? So we're actually getting the word out there, making sure people know that they can come to us and they have the ability to request a translator or ability to talk to us in different languages and access these services. Next slide. So another way that we're keeping and holding ourselves accountable is every year, well, we just started, right? Oh, sorry. We just started because we just relaunched, is we're doing an annual progress report on language access at HHS. So this report covers, how are we meeting our goals? Are we meeting our project timelines? And also where we're falling short and what more could be done. So our first annual report came out in May, so that was super exciting. And it talks about our progress to date and what we can do more. So some recent accomplishments, and I had to ask what this meant because it's also in legal jargon. But we have 25 divisions across the Department of Health and Human Services. So 19 of those have been able to offer what is called in-language services via their website listservs, and that's target languages for the communities they're trying to serve. So if they're specifically trying to serve a Vietnamese community, that resource is translated into Vietnamese, et cetera. And also, this one is really fun. The 20 components actually have telephonic interpretive services. So that means their helplines, you can call their helplines, and there's prompts for you to get assistance in other languages. Next slide. And then just as a wrap-up of what we're doing at HHS. So we announced that we're doing a language access plan, like what, you're just doing a report. But we're also doing a plan that's out there to the public. It's also translated in many languages to say, these are the best practices, and these are the best practices that HHS promises to follow. Some of the things that are really important is we provide guidance on video and virtual interpreting. So we explain that these formats can offer a greater reach to people, especially in rural communities, and also those who may not be able to access an in-person interpreter or translator. We also offer specific guidance on who is qualified to translate. You can find that on page 17. I know that you're going to go download that right after this. But basically, we recommend that you should have a university degree, you should be certified by somebody, and then you should have a few years of experience. So we're super proud of this. We also hired a language access coordinator. This is a best practice for any department to have. DOJ was actually one of the first people to have it. But it's making sure that we're coordinating across all of HHS to get the work done and to deliver what we need to deliver for the American people. Next slide. This is the fun part. So a lot of our job is not just doing regulations, but it's making sure people adhere to the law. And that was very different for me when I came over here, because I did policy for a very long time, but now we're enforcing the law to make sure people are held accountable. So I'm going to highlight a few enforcement actions that we've been doing in the language access space. Next slide. So Maricopa County, so Maricopa Superior Court. So when we think of Maricopa, you're like, that definitely seems familiar. Well, it's one of the largest counties in Arizona. It's usually really big during election time, et cetera. And it's actually one of the largest Spanish-speaking communities in Arizona, in the southwest of the United States. But what we were finding out is that they were actually not providing legal documents in Spanish or other translated languages that were for their population. And so we had a few complaints where people were getting their parental rights terminated. They were given the document in English when they were Spanish speaking, and then we had another instance where someone was given a legal document in English, and when they requested a Spanish document, they were basically told no. So we said, that's no bueno, we need to fix that. So we worked with them, we offered technical assistance, and they actually agreed to notify individuals with limited English proficiency that there were free language services available to them, and that court documents would be translated in languages as upon request. And then they also have audio and video recordings in the top 3 languages. So there's actually court proceedings that you can see in the top 3 languages for that county. So that was super exciting and a great result. Next slide. Another one related to the COVID-19 pandemic is what we were seeing during the pandemic is that a lot of states, were doing these testing sites, they were doing these vaccination sites, and they were putting things out in English, but they weren't really reaching communities who were non-English speakers, right? And so it seemed like states didn't realize that that was a violation of federal civil rights law. That's okay, we're gonna help you. So we decided to offer them technical assistance. So we helped 19 states understand what their obligations were and how they should reach out to folks and make sure that communities that were non-English speaking were able to access these services. So that one was really exciting. And we worked with DHS and FEMA on this one. And then lastly, next slide, we have the Medicaid unwind. So that's probably one of the most timely one. During the pandemic, the process for enrolling Medicaid enrollees was on pause. And so that process has started up again. And what we've been fearful of and what we have seen is that a lot of people are dropping off that's a technical term. People are dropping their Medicaid coverage, right? Because maybe they're not getting the notices, they're not getting the notices in their language, and they're not getting access to someone on the telephone because of long call lines. So we're looking into this. We want to make sure that we're understanding what states and what efforts they're making to reach out to limited English proficiency folks and making sure they're abiding by the law to offer language assistance services. So that one's ongoing, and so we're hoping to make sure states know that they've got to reach out to folks, they've got to abide by the law, and giving them ways to do it. Next slide. Oh, great. So this is the last slide, so we're wrapping up. I just want to say that, if you feel like someone has been discriminated against or is being discriminated against, you're welcome to file a complaint with us on our portal. It's this last one, ocrportal.hhs.gov. You can file on your behalf, but you can also file on someone else's behalf. So if they may not feel comfortable, that's totally fine. We may eventually need their consent when we start investigating, but that is something you can do. And then the other thing, as far as language access, if you have questions about anything that we're doing at HHS, or you need to get materials translated and we're not offering it on our website, you definitely can reach out at languageaccess@hhs.gov, and we'd be fine to receive that request and respond. And then that's it. All right, thank you.
Wonderful, thank you so much. So for our final panelist to present, we have Dr. Cheryl Martins. She is the director of the Institute for Advanced Studies in Inequalities at the University San Francisco de Quito. She has a PhD from the University of Manchester and is co-principal investigator for the Hungry Cities Partnership Project, Migration and Food Security in the Global South, and the Canadian Institute for Health Research Project, Food Insecurity Consequences of COVID-19 Public Health Measures on Marginalized Refugees and Migrants in Canada, Latin America, and Africa. Her latest publications focus on Venezuelan migration in Ecuador in the context of COVID-19 and sexual health and gender-based violence service provision. Welcome our next panelist, Dr. Martin.
Good afternoon. I'd like to begin by saying thank you very much to Maria Isabel Roldos for the invitation and all the incredible organization her team behind this event. And I'd also like to extend my thanks to President Delgado and to Emeritus President Fernandez as well. I think in terms of looking at health and equity, it's so important to have the support, the institutional support for this kind of work. And so on behalf of Universidad San Francisco de Quito, Instituto de Estudios Avanzados en Desigualdades, I'm very pleased to be here to be able to present a study that we've done with several colleagues in the city of Quito. This study is a national study that we did with the International Organization for Migration, and it's a study that took us approximately 2 years to complete. I will go to the next slide, please. Yeah, thank you. So the objective of the study is to look at migrant access to sexual and reproductive health services and also the provision of services for gender-based violence. There is a whole network that has been created with regard to protection services to try to reduce gender-based violence. And yet there is this legislation that is available. However, implementation is a major issue, and for that reason it was important to have a look at what was really happening. And so we examined the cities of Quito, Machala, Manta, Lago Agrio, and Guayaquil throughout Ecuador. Next, please. In terms of the frameworks, the methodological frameworks that we used, we were interested in trying to incorporate, first of all, human rights perspective, and looking specifically at the human rights of migrants, a gender responsiveness framework as well, and the capacity that is the capacity to promote equitable participation and distribution of benefits and access to services, as well as migration human mobility framework. We wanted to incorporate this because obviously, and that's the basis of our study, even though we are within our sample, we had included local population. This study has drawn very much on the Cancun adaptation of the UNFCCC process of human mobility, which not only encompasses displacement and migration, but also planned relocation. And the transversal approaches are feminist, intergenerational, and intersectional approaches that we used across the study as well. And in next, please. The methodology was a mixed method study. We used qualitative methods to interview city-level officials. We had 25 semi-structured interviews there, and national-level officials, 13 interviews, 35 semi-structured interviews with sexual health and protection service users, and 9 focus groups with local and civil society actors. So these are the local organizations and NGOs working with migrants and working in the area of sexual health and reproductive rights. And then we had 14 workshops with men and women, as well as LGBTQ plus participants to talk about sexual health rights and to understand the issues much more closely. Then we also conducted a survey. First we did a survey of the government data, looking specifically at the secondary data across all the different government ministries. It's important to mention that this study was done in conjunction with the Ministry of Health, and so that facilitated our access to the secondary data as well. And then we did a survey where it was 40% local population, 60% migrant population, and 70% women, 30% men. Next, please. Yeah, so in terms of these first couple slides, I wanted to just go over some secondary data that I consider important to mention to you, to give you a bit more of the context in Ecuador. So if we look at the national average when it comes to Ecuadorians versus foreign population accessing services, we have 97% Ecuadorians versus close to 3% of foreign population. Now, the foreign population in Ecuador is closer to 5.5%, so it means that just over half of them are actually accessing the health services, family planning services, rather. And I think it's one of the points that stands out here is the data from Lago Agrio, where you have like a much higher migrant and foreign population accessing services at around 15%. Now, this is important to note because Ecuador has much more accessible health services compared to Colombia, and so because Lago Agrio is on the border, we also have people coming and going to access these services there. So I think that that's important to note in terms of this data. But generally, the family planning access by foreigners and migrants is under the level that is in each of these cities. However, I think what's especially outstanding when you look at the family planning, if you look at by access according to men and women, we have 50% of the population identifying as men, yet only 3.71% of them are accessing any family planning services. And so this was some data that stood out to us, and we also found it really interesting when we had the workshops with men and women that, in fact, men, we were told, well, men are busy working, they aren't likely to come to your workshops. Well, everyone that we invited pretty well attended. There aren't many spaces sometimes for men to speak about family planning and sexual health. So I think that this data here is quite telling. Next, please. Yes, and because our study was also looking at gender-based violence, we wanted to have a look at the rates of gender-based violence, sexual violence in these different cities. Sorry, this is actually the femicide data, and we can see that it's much higher per 100,000 in border cities like Machala and Lago Agrio compared to Quito and Guayaquil, even though these are much larger populations of millions of people, the percentages are much higher. And we are seeing this now with regard to all the violence on the coast of Ecuador, that there's an incredible increase, a tripling of femicides, and related to especially gun violence. Guns have become legalized on the coast of Ecuador, and this has had a direct repercussion on femicides on the coast in particular. Then we also have a quote here that I'd like to share by a hospital protection service worker, and she says, officials naturalize violence. Protocols are not followed due to lack of training, lack of interest. In 50% of cases, police officers make the victim retract their statement. It's much more common in migrant women because they have no family networks, no papers, and they're told, I need your ID card and the aggressive data, and they don't know necessarily the address. Next, please. Okay, so just to go over very, very briefly some of the survey findings, I'll share at the very end the access to the full report. But for me, what's really important here today is to be able to share with you some of the migrant voices, so I'll be focusing a bit more on that, and I encourage you to have a look at the data in the report if you're interested. One of the volunteers within the community organizations that we worked with said that the role of the community is fundamental, yet it receives very little attention and work with migrants. And here on the right-hand side, this is the invitation that we sent out to migrants to participate in the survey. Next, please. Yeah. And so when it comes to the access to services, the foreign sexual health service users were the ones who were least likely to have access to sexual health services, so 56.1%. And nationals, only 43 compared to that, 43% said that they did not have, 43.9% said they did not have access. When it comes to the access to services, of those who did say they had access to services, more than half said they did not have, and these are migrants, sorry, I should clarify that, they had not had access to services within the last 12 months. The main things that they were accessing were contraception, cancer prevention, and also to have checkups for pregnancy checkups. And then they have, those who have accessed services, they've also done it to check for STIs. But one of the things that we were encountering time and time again in terms of the stories of migrants is that they did not get they did not get the attention that they were expecting. So for example, in this case of one Venezuelan migrant woman, she says, to have my C-section stitches removed, I had to wait in line with 30 people with my just days-old baby girl in my arms because the doctor told me I didn't take priority and that I should just wait. Next, please. Okay. And so when it comes to the lack of access to services, well, again, we were speaking earlier, the presenters mentioned, the importance of rights and knowing about your rights. Well, here we have a very good example of how the majority of people who said when they did not have access to services, well, it was because they didn't know really where to go in terms of, what were the processes, how could they actually access the services. And they also had major issues during the pandemic, okay, because the survey was conducted between 2021, 2022. The folks who were trying to access services were told, well, sorry, not available today because of the pandemic. And then issues of financing, of how to get access to the internet, sometimes to book appointments, to be able to get to the transportation to get to the services was another major issue, as well as lack of documentation. They felt that they could not attend if they did not have the documents. Now, in Ecuador, it is possible to attend if you have the documents, if you don't have the documents, but a lot of people don't know these rights. Okay, and then when it comes to people living with HIV, one HIV positive male migrant from Colombia, he explained his situation, and he said, I have had a difficult time without my treatment, and I feel I'm being judged morally. And one doctor even told me that my illness was a result of a straying from God. Next, please. Yeah, and so here you can see the variety of repercussions that there are from not accessing healthcare services, and a lot of them, 33% were related to to not having, to having complications in pregnancy, also an increase in sexually transmitted infections, and their illnesses worsened. It was in the case of 15%, as well as unintentional pregnancy. Miscarriage, fertility problems were the main ones that were mentioned. Okay, and then here we have a focus group participant from Machala who states, we have reports of women who have not been able to get an appointment for a year, such as general medicine, for example, and they've not been able to get an ultrasound or have not had access to prenatal checkups. If we are going to see that there's, in this person's opinion, we're going to see that there is an increase in teenage pregnancy, and they're very closely linked to sexual violence. So the rates of sexual violence, too, I wasn't able to give too much detail, but definitely during the pandemic, these increased significantly. And then we also have some data here regarding gender-based violence, of where it mainly occurred, and so the women, especially, that mentioned that they had had to deal with gender-based violence, 61 or almost 70% said that it took place at home, as well as at work, and close to 24, almost 25, well, 24.23% in public spaces. It's interesting as well for migrants that 20% was along the, during their migration as well, okay, in the trajectory. And here we have a statement from a male workshop participant who said, single women are at risk of being raped, and sometimes to cross a dangerous crossing point, they have to have sex with the human traffickers and with whomever the traffickers decide. There are many who disappear and they're never heard from again. And next. Okay. And then we also have a major issue of impunity, okay? So why are people not reporting gender-based violence, okay? One Venezuelan woman migrant says, well, they take him away, but nothing happens. They release him at the corner. They cannot even be bothered to arrest him for a few hours to see if he gets scared and leaves me alone. And this, actually, this is data that was similar for local population. And one of the things when we had the Minister of Health read our work, they said how shocking it was that the general population also is going through many of these same issues. And so why did they decide not to report? Well, they didn't know who to turn to. Okay, thanks. And when it comes to the main fears, they found it very difficult to talk about this, and also they were afraid of their aggressors. Those are the main things. Okay, so just next, please. It's really important to note here that we have, next, please, next slide, thanks. We have lack of state resources in Ecuador, and we make our best efforts, but limitations of human resources are affecting us. To date, we have had a backlog of almost 6 months when it comes to violence assessments. So there's a lot of things within the system that make it really difficult to process these gender-based violence cases. And there's a lot of issues around like people actually who are working within the system knowing as well how it works. So I'm just going to move ahead. The next barrier I just wanted to mention is really important is the xenophobia and transphobia. Next, please. Yeah, so the police have kicked me, put me in jail, threatened me, left me to die when they recently attacked me. Now they are calmer because they know that I am not alone. The organizations like CARE International and IOM and Puerta Violeta are with me. I don't trust the authorities because the only thing I have received has been mistreatment and violence. Next, please. Okay, so in conclusion, we've had a very partial implementation of official protection legislation. We've had insufficient resources for policy implementation. This includes budgets, human resources, as well as training. sparse, multi-level information sharing and coordination, and then weak human rights-based approaches when it comes to provision of services, as well as the absence of health promotion and prevention programs oriented towards addressing gender power relations, masculinities, and positive parenting. There are also disparities and gaps in functioning of the health and protection systems between territories, as well as institutional violence and xenophobia within the protection system. And urgent issues are the need for case follow-up and comprehensive reparations for victims of gender-based violence, and need to address incest, rape, and teen pregnancy. Next, please. Have a series of recommendations based on these. But one of the things that I think is important when we don't have actual funds to be able to work on in relation to these services is to look at how we can strengthen intersectoral collaboration, as well as prevention and awareness programs. Last slide, please. I welcome you to have a look at the IOM study. Thank you so much.
Many thanks to the panelists for presenting. We would like to invite you to the front to have a quick Q&A. We will begin with doing questions from Dr. Gural and myself, and hoping time permits, we will open it up to the public. Thank you.
So I guess we'll start with the first question to Dr. Hernandez. Can you talk a little bit about how the lessons from the Dominican experience can be applied to other Latinos groups or Hispanic groups?
I can... Se oye? Se oye, right. I think that in the majority of the cases, when you look at America Latina, the majority of the people that come from America Latina, I think that they share, and that will be the Dominican and the rest of the people from America Latina, they share the fact that they are people who are not wanted in their own society, the majority of them. And that, of course, exclude those that are living because so, I guess, you know, who come here to study or something like that. But the majority of the people that come from America Latina happen to be workers. And when you look at their sending home, there is issue, home, accessing jobs. And as one of the speakers was showing, accessing health. It's not only for the migrants, but I'm sure that it had to do with the impoverished population of Ecuador, for instance. So I think that that's one of the things that unite Dominicans with others. They're not necessarily wanted back home, and they are simply let go.
Wonderful, thank you. So I'll take the next question for Lauren G. Can you discuss some challenges working with interpreters and how they are addressed?
Sure. So one of my first experiences with an interpreter was when I was in law school, and we were in Memphis helping young women who were seeking asylum in the U.S. who were victims of domestic violence. And so they gave us a quick training about how to work with an interpreter, and that has stuck with me. But I think a lot of times, you know, health providers may not be used to this, and so they definitely need a training. And so one of the things they told me is that when you're speaking with a person, you're making sure that I'm talking to that person directly, and that I'm not heavily relying on the interpreter to do that communication. So my body language, my eyes are looking at the person I'm trying to communicate with, and then the interpreter is at my side interpreting for me. So I think that's just a basic thing that health providers need to adjust to when they're using an interpreter. The other thing that can be difficult for an interpreter is maybe they don't have a background in medicine or medical knowledge, and so when they're interpreting, they may not have a grasp on the words to use for like complex medical terminology. You know, this is something I saw with my father and my grandmother. You know, he was able to speak Cantonese fluently, and he was also a medical doctor, but even then, there was still somewhat of a language barrier between the two, expressing in Cantonese the terms for my grandmother.
Our next question will be, our next question will be for Cheryl. What are some of the main strategies you have observed migrants use in order to overcome barriers to accessing health services?
Well, hello? Yeah, hello. Okay. All right. The main strategies. It's not working. All right. Okay. What's especially notable are the strategies of reaching out to organizations to be able to get access. Without having someone to help mediate, it's really difficult to actually get access. And so for that reason, a lot of migrants actually turn first to NGOs, local NGOs or international NGOs like CARE International, or international organizations like the IOM to be able to get access to these services. And so that's been an important strategy. But they also have great networks. Along the way, they know where to reach out to for support, different local organizations that they can connect with, and so on. And so through their own networks, I think we've also seen that they've been using social media for that.
So we're going to put a general question out to the three panelists, so feel free to chime in when you want to. The question is, in your experience, how might policymakers and practitioners most effectively address discrimination toward migrants in health and protection services? Any thoughts?
That one's more straightforward for us, in that we enforce civil rights laws. So yeah, I think what can be hard though is not receiving the complaint. So our investigations are definitely complaint driven. So that's why I encourage you that, you know, if you've been discriminated against or know someone, to definitely file a complaint with us. You know, it's one of those errors of like you don't know what you don't know, and so that can be really difficult. But in addition to receiving complaints, we can also do what is called a compliance review. So a compliance review is something that we read a series of news articles, we have conversations with the community, and we're hearing about discrimination that way. And as a result, we can proactively do an investigation that way too. So sometimes when we do community meetings like this, or we travel to other places in the country, if we're really hearing about an issue that we're just like, whoa, what is going on? We can initiate that investigation.
All right, try again? Okay. For policymakers, I think first of all, it's really important is good data. And in Ecuador, when we were doing this study, we realized that there was not really coherent data between the different government institutions. And so that in itself affects the decision-making that can be done. But then the other thing is too, I think it's important to look at how things are sometimes too highly centralized, or maybe sometimes not centralized enough. I think all that, the actual, like, the levels of decision making need to be looked at as well. And then also the implementation stage. This is where we saw that there was lots of great laws and lots of good legislation, but unfortunately, there was not enough focus on implementation and actually carrying out the budgets. And so I think that that's another aspect that needs to be looked at more carefully.
I think Thank you. Do you want
If I understood your question, well, I think that looking at the communities, it's key here. Every community is very structured, despite what people might think. You know, sometimes they think that we are very disorganized, and that's not true. There's an internal structure in every community, and understanding that structure and speaking to the people inside those communities will get you and will get the policymakers where they need to go.
Thank you. And that sort of takes my mind back to the beginning part of our presentation this afternoon when the local representative was here with us, indicating starting open hearings and the opportunity for the community to voice their experiences and challenges. And just what I'm hearing here, it seems like that's also a good starting place for those local representatives to be engaged with their communities, understanding them. And the data, of course, very essential. And as a university, we are here with that opportunity as well to make collaborations and keep the data coming in and analyzing the data. So.
And I'll just add, from my time, I spent 10 years in Congress, which was wild. But you have the Senate and the House, right? And so one thing that I would encourage folks at this table and in the audience is that, you know, you have a voice and you should definitely be weighing in with your senators or your congresspeople about things that you care about, because that's when we get feedback from the community, especially we hear it enough and long enough, so be a squeaky wheel, then that's how we just make our policy decisions to draft legislation and later try to enact it and pass it.
Thank you for those recommendations. And I'm sure we have a number of individual students as well, so pointers and tips. I believe we should have, we have a couple of minutes for a few questions from the audience. Is anybody burning to ask a question? Yes. So there's a mic coming around. Thank you.
Hi, everyone. My name is Jocelyn LeBron. I am a healthcare advocate. I cover the Bronx, actually, with 1199. And my question for Dr. Fernandez was your employment data for Dominicans in New York City. How much of that data was based on Dominicans who are undocumented or both documented and undocumented? Because I know that employment data can be hard to get in that sense.
Yeah. This is data from the census of the U.S. I think we use the decennial census. Whenever you see 2010, 2020, or something like that, is the decennial census. And in other occasions, we use the American Community Survey that is done between the years of the census. So the understanding of everyone is that the census should capture every individual, right, whether it's documented or undocumented. But we know that many people, and many of those are people who don't have the proper documentation here, might not answer the questionnaire of the census. So we will not know the answer to that question. This is strictly census data as compared to the wonderful survey that the professor from Chero presented.
Hello, I'm William Suarez, professor of Health, Equity, Administration, and Technology. So, Professor Hernandez, I have a question just for you. In my mind, I'm just saw one of your graph figures. What happened in 2012? Because I remember one of your line graph shows like was basically a reduction, significantly reduction in the number of Dominicans uninsured. And it came to my mind, I said, what happened in 2012? Because it's basically if my memory do not betrays me, the graph was basically stable, and then it was precipitated in 2012 and then still going down. What happened in 2012? I don't remember.
I had trouble with everything, my eyes, my ears, and everything, so I don't know if I captured your question. But the question that we have here, and I don't want to give too much of the study that we are doing now, is that despite there's so many negative stuff with the Dominican people happening, right? In terms of income, for instance, in terms of families headed by a single woman, negative in the sense of how it's taken in society, not in my point of view. I think it's pretty good, you know? The question is, why is it that Dominicans have such a high rate consistently, right? In getting, health insurance. And you're right, when you compare the groups from 2010, I think it is, to 2019 or something like that, the drop of those who didn't have insurance was phenomenal. So meaning that there are more Dominicans with insurance than others, right? I promised that I was not going to tell you the answer to that question because, you know, we asked the same question as well. It's coming out. The study is coming out, and it's going to answer why is it that we have responded in a way, in a very good way, to this thing, and that we do have insurance. So I don't know. I just simply don't want to give you an answer. Sorry. No. It's a study that is coming out. I want you to read it.
We will be waiting for it very excitedly.
Oh, we have a question.
So do we have time?
One more question.
One more question?
Firstly, congratulations to all the presenters and Dr. Roldos for organizing such an engaging discussion. My question is also for Dr. Hernandez. We saw that in the upcoming study at the Dominican Institute, you were looking at health insurance, access to health insurance as an indicator of like just understanding access to health. But we know that access to insurance does not necessarily mean utilization or good quality healthcare. So are there any other indicators you're looking at for that study? That would just be interesting to learn.
I mean, you nailed it. Yes, we are looking precisely at those questions. What is the meaning of having health insurance in the case of someone like the group that I show here? You just nailed it. Yes, those are important questions. What kind of health insurance, and what are and what does that health insurance give you access to? Yes, definitely. And if I'm allowed to ask a question, Cheryl, I was wondering, one of the things you say is the majority of the people at that moment were male. I think it was over 50% or something like that, of the people interviewed. And then only 3% of that group had access to information and healthcare and that kind of thing. And I wonder whether you have compared the migrant population access to these things with the native population of Ecuador, and see whether there are differences in terms of this. And I know there's a question of class here, right? Just out of curiosity. And the other question related to that is, what prevents them from accessing when the law in Ecuador apparently allows migrants to do this, to have access, as compared to other countries in America Latina, that is not necessarily the case.
So I'd just like to clarify. On the left side, when it came to access to healthcare services, this is data, national data looking at, on the one hand, we presented migrants versus local population, right? So the local population versus migrant population in Ecuador is around, well, migrant population is around 5 to 6%. We're actually getting closer to 7, probably around 7% by now. And so the access to health services was generally around 3.5%, sometimes a bit more, right? So only about half, that meant that only half of the migrants were actually accessing health services. And on the right-hand side of the slide that I presented, it showed generally men and women. That included migrant population, actually. And so this is why it's an issue like across the board. So yeah, your point is very important, that they're not accessing, men are not accessing healthcare, sexual health, family planning services. So why is this, right? And so that's why I also, mentioned that we weren't expecting all the men to come out to the workshop, right? But then they were all really excited to come to the workshop. They want to come. My gender class now at University of San Francisco de Quito has more and more men that want to be part of the discussion. We need classes on masculinities. We need discussions of family planning, and not just orientate. And part of the issue that I found on this in the study was that so many of the services were orientated only towards women. And so, well, what about the men? I mean, the men, if we want men to take responsibility for healthcare and sexual health, we need them to be part of the conversation. And so this is, I think, where we'd like to next take this research, because we find that it's absolutely fundamental, especially because of the high rates of incest and rape that we're seeing as well in the case of Ecuador. So I think that, yeah, this is a really key point. So the sexual health access, is directly reflecting that as well. Men are not, they're not the expectations that men are actually going to access these services when perhaps many more of them would if they actually had, the chance to be part of this conversation.
Hi, sorry.
I think we're out of time, but
that's fine.
panelists will be available if you have any questions after,
yeah,
but we have to stay within the time frame that we have for the live stream. So I want to thank Ramona, Lauren, Cheryl, Mira, and Naomi, especially for being part of the keynote panel. I want to take the opportunity to thank my staff. The students, we have the Lehman Latinx Medical Pre-Med Medical Association, Crystal Reynoso and Daniela Avila were key implementers. My own team, June Towns. I want to thank everybody that was part of this summit in the organization. We do have in the plan closing remarks from Dr. Amanda Sisselman Borja, and I'm going to go ahead and say her key points in her address. So please accept me as her interlocutor, as she was not able to attend. And to this end, I will read her final remarks. Dr. Amanda Sisselman is a licensed social worker and associate professor at the Department of Social Work. Please accept my apologies for not being present. COVID found our family, our household, and it's been difficult 2 weeks. I would like to thank Marisabel for her understanding and for offering to read my comments, and I'm honored to have been asked to provide closing comments for this important panel. The Bronx is home to 27 dominant languages spoken in households across the borough. This richness in culture must be embraced. We have recently heard much about the many media outlets termed the migrant crisis in New York City. Although it may be seen easy at first to feel frustrated by the overload of shelters and schools and their basic needs services providers, I think we need to take a step back. Data not only knowledge, but it's also power. As the CUNY Institute focused on health inequalities, we embrace these relationships that we have made during this 2-day summit with community organizations and community partners. Together, we can continue to have a robust study designs that yield numbers to give us an idea of the scope of the issue and include interviews and voices of our community members. As a clinician, a researcher, and a teacher, I wear many hats. All of these hats have helped me foster relationship with community as a true of them all as an affiliated faculty. I work closely with youth in the community and organizations that serve them. My work would not be responsible if it were not for the people that run these organizations, including crisis centers, drop-in centers, residencies, schools, and hospital centers. We work with people on the ground, clinicians who rely on the data that make shifts in their own practices, and in turn, we rely on these clinicians and the people that are served in order to conduct studies that inform best practices. These mutual relationships between organizations, faculty, researchers, are what we will strengthen at the CUNY Institute for Health Equity. We must work together and build a portfolio of community ideas and work together to resolve these needs. Poverty will not disappear without an effort. Lawmakers and funders need compelling reasons to put money into programs in new policy. It is up to us at CIHE to bring our communities to the research table and frame studies that will provide the data and compelling stories to drive new programs and policies supporting poverty reduction for our communities, including foreign-born New Yorkers. This is where the work begins. As a faculty researcher and an institute dedicated to the study of health equity and the dissemination of research that informs policy and practice, we have led the community in finding answers to this and our pressing question. As a colleague and I, in our work in the department, we recently were awarded a small grant to work with the Rockefeller Institute of Government to systematize the literature on interventions and service to foreign-born New Yorkers and to make recommendations for future research and practice. While we're still in the knee-deep of the literature and our work in this project is yet to be complete, I can assure you that there are people doing great work and making good effort, but there remain many gaps in services provision and outreach that go beyond insurance provision. Again, this is a necessary first step and one that must be accomplished for all, but providers need guidance and concrete suggestions to help their patients navigate poverty and associated programs. We hope today, in the last 2 days of the summit, activities can be jumping off point for connection and collaboration between CIHE, community-based organizations, community members themselves, to begin to solve the problems associated with social determinants of health that have mentioned today. I hope that in the health equity researchers, we have leveraged our resources and the voices of the community to make impressions in our local lawmakers and state legislators. Together, we can have the power, we have the strength in numbers. We cannot do this alone. Social justice, health equity must remain at the forefront as we march down the road towards 2024 and potential changes in leadership. As I conclude my remarks, I wish I could be there with you in person to take comments and answer questions. I encourage you to please help use my email anytime to engage in conversation, and I hope to meet you all in the near future. Amanda Sisselman Borja. You were greatly missed. And with that, we will have just finals, concluding remarks from the provost. Provost Jorge Silva Puras has a recorded message for us today, and we'll be playing immediately after. And with that, we will give conclusion to the summit. And for me, thank you very much. A warm thank you and welcome to everybody at Lehman and at the Institute. Thank you.
Thank you for attending this wonderful summit. I want to thank first and foremost the director of the CUNY Institute for Health Equity, Dr. Marisabel Roldos, who has done a phenomenal job at organizing this event, which I hope has been as productive for you as it has been for me. I had the chance to meet some of you yesterday and had really a phenomenal experience learning about the challenges in terms of health disparities, particularly as it relates to our population here in the Bronx and in the city of New York. Also, we learned about the challenges that migrants also face when they come to New York. And we heard from professors and experts coming from different parts of the world, including as far away as Quito, Ecuador. So again, I do want to thank Dr. Maria Isabel Roldos and Dr. Noemi Rodriguez from City Tech, who did a phenomenal job at organizing what I am sure you all recognize has been a tremendous event. Now, I also want to mention some of our sponsors, and I do want to thank them. because this has been a collaboration that has included not only Lehman College, but other CUNY institutions, as well as NGOs, nonprofit organizations, and community-based organizations. And those are the Borough of Manhattan Community College, Bronx Health Link, the Dominican Studies Institute, the Lehman Latinx Medical Student Association, the Lehman Leaf Library, our very own Mexican Studies Institute here at Lehman, New York Humanities, and finally, the School of Health Sciences, Human Services, and Nursing. I hope that you will join us again next year at the next summit, where we will embark on continuing that relationship that probably you have already started building, from connections, from participating in workshops, participating in panels, and creating those long-lasting conversations and partnerships that will drive us to a better future here in the city of New York. Thank you.